our monthly Inspired Spine Case Conference. Usually we have it the Saturday of the month, but the first 2 Saturdays of the month I was in Amman doing surgery my Amman hospital, so we couldn't have that. And this as well is our so-called peer review process. I hope everybody has signed the HIPAA compliance because we are going to discuss. Good morning, David. Because we are going to discuss actual patient cases. And as well, all the information exchanged here is peer-reviewed protected. So that is why we talk about difficult cases and complication if needed to be. And so this is all peer-reviewed and not discoverable. This is part of our process that we have put in place for the last 3 years that enable us to learn all the everything we do. Now, I have a very interesting case, but before I start my case, I want to talk about, what do you guys, if anybody has an announcement or a case to discuss?
Did you see Dr. Eun-Sang Kim?
Yes,
Hamid.
yeah. We introduced, you introduced us in Alex.
Yeah.
Hey.
He joined the meeting.
I still think
Hello, everybody. My name is Eun-Sang Kim. Kim is my last name. Eun-Sang is my first name. I'm working at Samsung Medical Center, Seoul, South Korea. I visited Minneapolis, Dr. Sonny Kim, and I met Dr. Abashi in his office in Alexandria. I am very much interested in OLLIF or LIF, and I would like to experience some cases after I coming back to Korea. Thank you. I'm very pleased to participate this meeting, web meeting. Thank you. Thank you, everybody.
Well, welcome, Dr. Kim. We're really honored to have you here. And I hope that, you get a good exposure about who we are, what we do. Now, so far, that's, I'm sure you guys were in, you have been participating in some of the surgeries. Sonny, what kind of surgery did Dr. Kim had the opportunity to observe with you?
He hasn't seen any cases. We got 5 cases this coming week at Riverview. Fairview Health Services, they would not allow any foreign doctors come and observe surgeries.
No,
So
they don't allow American surgeons, so they don't allow any visitors. They're still being very cautious about the thing. But so you're scheduled to take Dr. Kim and show some cases in Riverview.
Yeah, we got 5 cases Tuesday and Wednesday. He's going to see 2 olive cases and 1 cervical thoracic cases and 1 microdisc and just hodgepodge of cases there.
Now, Dr. Kim, the Riverview is one of our better system, not because they are a big hospital, but because they give us resources truly to perform what we do. Like,
okay,
yeah,
I'm very much expecting. Yeah.
Now, last Wednesday, just a few days ago, I did 4 cases in Riverview.
Oh, really?
Standard, the small hospital. We started at 9 a.m. Actually, the cut was 9:15, and the last stitch was at 2:45. So, in 6 hours, we did 2 3-level olive fusions, and 1 sacroiliac joint fusion, and a cervical 2-level fusion. So, they really give us the resources, and so we can do 4 cases under 6 hours, and everybody's home at 3 o'clock. So that is truly what we are able to provide. And but having said that, you will. I'm hoping that when you go there, you see with your eyes that Dr. Kim, how he can perform in a smaller hospital, at what level, even in a smaller hospital, we can perform. Now, Let's first of all, you're in Seoul, South Korea. Is that correct?
Right. I'm working in Seoul. Right.
I would love to know a little about your experience there. Like, how big is your hospital? What kind of cases do you do? What is your volume? What is your workhorse for fusion, like TLIF, PLIF? Can you educate us a little about the kind of cases you do, how big your hospital is in Seoul, South Korea? Would you mind to educate us a little while I'm setting up my presentation for a case today?
Mhm. You mean how many cases I do in my school, in my hospital?
Yes. Tell us about the case composition of your hospital.
I'm doing degenerative spine, and I do TLIF instead of PLIF or anterior approach, LIF. I'm doing some cases OLIF, OLIF with Medtronic lateral cages. And the half of my work is spinal cord tumors. So I'm a neurosurgeon, so I frequently do the intrathecal spinal cord tumors. But many degenerative cases come to my clinic, and most of them are elderly patients, and I'm interested in my, the MIS, minimal invasive approach, and that is why I'm interested in the OLLIF, OLIF, and
So what is the volume of fusion volume in your hospital?
I'm doing about 100 cases a year for fusion, and 150 cases for spinal cord tumors.
Yes. So you're specialized spinal, because that is a very high volume for spinal cord tumor. So you're practically the authority on that, because with that volume, anybody in the United States would be the authority on spinal cord tumors. Most of average surgeons in the United States, they do maybe 5 of spinal cord tumors annually. So,
really?
Yeah, so your case volume is very high for the tumor. Now, having said that, now why don't you open up our cases today for conference. Now, does anybody has a case to present?
Dr. Kim, you should also say how big is your hospital is. One of the largest hospitals.
Yeah, I'm working at the Samsung Medical Center. It is have a 2,000 beds, and we have a specialized cancer center in the same campus. So many referral cases from all over the nation to treat the cold tumors or spinal primary tumors or metastatic tumors. And this is my first time to participate this web meeting, and I didn't bring my cases because I thought I don't have any chance to present my cases. So next time I will present cases.
I have a repository of over 1,000 cases. So I can, for the next 1,000 meeting, I can present cases, but I don't want to be the first person. So Sunny or Dr. Milani, first of all, good morning and welcome to our meetings. Now, and as well, if anybody has a case, please let me know. Otherwise, I have a difficult case I want to present with some up and downs here, and that is where we learn from. This is not about gathering personal glory. It's about the difficult cases, the questionable cases. Those are the cases that we learn most from. But
how many cases have you done in Oman, and what are the case mixes? You said you just came back from Oman.
Yes. Now, first of all, For everybody, I just came back from Oman. We did 8 olives and 2 sacroiliac joint fusions in Oman. And they sent the Mercedes from the palace to chauffeur us around. I think the license number of the Mercedes was like 3 digits or something. So they really treated us really well. And I did surgery on many high-level military people as well, because I was invited to a military hospital there, including I did a surgery on a mother of a cabinet level. Knock on the wood, thanks God, everything went well. Otherwise, I don't know if they would have let me out or not. And I was presented with the national symbol of their medal, this Omani Khanjar, they call it, and so on. They really take care of us, good. And by the way, I met with they have a sovereign fund, they call that Omani Investment Authority, where the oil money goes to. And this is practically the excess oil money goes to that fund, and they invest it in the infrastructure and economy. And I met with the cabinet level person in charge of that. I couldn't meet the Minister of Health because he was in a different meeting out of country. But they asked us for a proposal to build a hospital in Muscat. And as well, in the same meeting, I met with somebody, actually very high-level surgeon from Saudi Arabia, who is building a whole new center in King Abdulaziz in Riyadh. And John and I, we just talked to him just about an hour ago, where we are as well invited to build a center in Riyadh, Saudi Arabia. So it was a very, very good visit. And our results, they have not, sometimes I was telling to John that we get so used to what we are doing, we don't even know how far we are ahead of the curve. But literally, I got feedback from the whole hospital in Oman. They have never, not even seen something like that. They haven't even heard anybody being able to do a 3-level fusion in 1.5 hours and send the patient home next day. This is unheard of. Not even they haven't seen that, they haven't even heard of it. So that area is ripe for us to go in and bring our service in. So that was a very good visit. Now, having said that, let's concentrate on our learning experience today on this case, which is a difficult case, but that is where we learn most from. It's a patient. Does anybody else have a case to present before I present this case? No? Okay. So this is a patient that I'm going to present that I'm going to share the screen with you. Obviously, all our patients have already maximized non-surgical treatment and so on. This patient, the date of birth is 1963. So patient is about 60 years old, not very old. But this patient is not a very healthy patient, has lots of comorbidities, and very actually skinny patient. And for the last 10, 15 years, severe axial pain, severe radiculopathy that has been truly not responsive to non-surgical management. Now, we do it as our usual things go, is that I open the floor, you ask about what information do you want to have, and I will give that information to you, and then we make a decision together, and then we go through the process, what we did, how was it afterward, and why this is worthy of a presentation in our meeting. So let's start with Monica. You're here online, correct?
That would be correct.
Yeah. So, Monica, this patient comes to my office. So, first of all, what information additional to what I gave you would you like to have regarding this patient?
I would like to know if she has radiculopathy, or if her pain is more localized, if she has the axial pain or the radiculopathy, how long she's had that pain, what her limitations are.
Good. Let's go one by one. So patient has the symptoms for 15 years.
Okay,
through over the years through multiple bouts of physical therapy,
okay,
including radiofrequency ablation, and has been offered, multiple different, pain management, including spinal cord stimulation device and so on in the last few years. The axial pain is predominant symptoms. 8 to 8 and 9 of 10, any activity make it worse. Patient does have claudication with walking distance of 5 minutes. After that, she said she just have to sit down. You ask about the radiculopathy. It is a scattered, that is not the same on both sides, but practically patient has both anterior, lateral, posterior thigh pain that with certain activity get worse.
okay.
So please, what other question do you have? Anybody, please open the floor. What other information would you like to have before we go to the next step? This is the first visit I see the patient in my clinic.
Is the pain better when she lies down?
Yes. Weakness. Anybody wants to know about the weakness? So a patient has 4 the hamstring and 4 left tibial anterior weakness. It obviously exam is somewhat pain limited, but patient does have some true with the proper exam does have some weakness, but it's not a high grade weakness.
Is she improved with leaning forward?
She has the shopping cart sign, yes. When she leans forward, when she goes shopping and so on, leans on the shopping cart, that she has the typical shopping cart sign.
And does she have neurogenic claudication too?
Well, she does that. She does say that when she walks 5 minutes, she has to stop. She just cannot carry on anymore. So, yeah, and I think she does have neurogenic claudication. But sometimes the neurogenic claudication is really difficult. Now, she does have leg symptoms after 5 minutes, but mostly what makes her stop is the axial pain. So it is not really clear, what the nature of that lies. Is it truly the spinal canal stenosis is just the axial pain? But she says that after 5 minutes walking or standing, she just has to sit down.
Hamid, did you measure scoliosis with her weight-bearing film, the whole spine with her standing? Because when she stands, this is supine film.
Yeah.
So when she stands, the scoliosis might be twice as worse as what it shows on the coronal CT.
You're absolutely right. I think we have those pictures somewhere, but you're absolutely right. Generally, when people get a CT and the scoliosis, the Cobb angle is a number. When they stand up, it's usually about 30% worse in average. Some people, you're right, some people can be twice as much, but in average, about 30 to 35% scoliosis get worse from the laying down to standing.
So you might be dealing with 60-degree scoli case here, lumbar scoli case.
That is true. That is true. And I did measure this here in the worst levels. It seems that between L4 and L1, that angle, it doesn't let me now measure that properly, but it seems right now here about above 30 degree, but it probably is much worse in the proper measurements.
Well, low back pain is worse when she stands, and it gets better when she lies down. So she might collapse like an accordion.
Yes, and that is the point, that this is a good sign that when she stands up, the anatomy changes. Now, does anybody want to as well mention the torsion here that you see in the axial?
That's scoliosis. That's indication of how bad the scoliosis is.
Yeah, and that is so. Any other clinical information, and then you want to have? Then let's open up the floor about what option should we consider. What option should we give to the patient? And no other question? So let's go around. Monica, let's start with you, and there is absolutely no wrong answer, okay? There is-
Okay.
they say there is 9 ways to skin the cat, whoever does skin the cat, but among the lines, there are 900. There is no right or wrong answer. So this patient is in your office with the information that you have gathered so far. What question do you have for this patient?
Well, I mean, just given the information she gives to me, I guess first of all, I would ask her, what her goal is, like, I mean, because, given her, well, she's not terribly advanced in age, but, I would ask her goal, because some people that I see.
You're now welcome to work for
Okay, Bob, do you mind to mute your thing? Good morning, Bob. Now, her goal is to be pain-free. He wants to walk and be pain-free. She's
Well, I mean,
of pain.
yep. So just looking at her views here, like especially the sagittal view and then the coronal view, and just seeing what her spine looks like. And I would say that, to offer PT or even injections, and if she's already had RFA, I mean, that's not going to do much at that point, because I see at the L1, 2, 3, and 4, she's got degeneration, she's got osteophytes. At that point, if she said, I want to be pain-free, I want to be able to walk, farther than I'm walking now, then I would refer her to you for an OLIF.
Well, no, yeah, I mean, but let's talk about all options. Now,
Okay.
Dr. Schultz, you are the most advanced pain management person I know. So this patient is in your office now with the information you have. What other information do you want to have? And what would be the option of this patient in your clinic? Is David with us? David? Okay, well, David maybe not right now here, but let's start, Dr. Milani. This patient with these findings is in your clinic. What options do you have for this patient? Now, what I want to emphasize is that this is not a very healthy patient, has lots of comorbidities, including diabetes and so on. This is not a super healthy person.
Yes.
But not super healthy person. So what option do we have available for a patient, for this patient?
Yes, I would like to have some diagnostic, at first neurological examination. As I'm one of the colleagues said, neurological examination about the sensation, paralysis, motoric, and so on, and about urination and the history is very important. For example, has she some trauma or not?
I'm sorry,
And
Dr. Milani, we have you on two different windows.
Yeah, two different shots.
We have you on two different windows. You have to mute one of them, otherwise it will echo.
you can see me. Yes, I can. Yes, it's okay.
Yes, better.
It's better. It's better. Yeah.
Yes. And the history is very important. And you said the patient is not healthy. I would like to know about the oncological problems and so on. Here, it is not problem, I think. But all of my patients, if come to my clinic, I would try to have three sort of diagnosis: X-ray, MRI, and computer tomography. And in all of these diagnoses, I can diagnose correctly. For example, functional X-ray said to me is this scoliosis or spondylolisthesis is stable or is not stable. In CT scan, I can find if the patient has spondylolysis or not. And in MRI, I can know about the spine and about the stenosis and so on. Because of this, I try to do all of this diagnosis, and with history of patient and neurological examination, I can understand the correctly the reason of this problem in this patient.
Okay, great. David, this patient is now in your clinic with the information we provided. What other information do you want to know, and what option would you give this patient in your clinic?
So what we think about is, first of all, well, anything we do, I'm a pain doctor, so I'm not a spine surgeon. And we tell the patient, we cannot fix the structural problems that are causing your symptoms. We might be able to mediate pain, manage your pain with injections and implantable pain control devices. So we kind of set that stage. And the first thing we would try is just a simple interlaminar epidural to see if reducing intraspinal inflammation might give symptom relief. Sometimes that's helpful for weeks and maybe even months. Pain docs are also using interspinous spacer devices for people who have central stenosis and they're better with leaning forward. And that puts them in this kind of flex position. I know spine surgeons are often not happy about that. And I don't do that procedure myself, but there are various interspinous spacer devices that are sometimes used. This lady seems like she has multi-level problems, and I don't know that would even be, feasible, but
one of the things, first of all, the interspinal device processes, as all of you know, what they do, they use the fulcrum effect by putting a device in the spinal process to open up the foramen. We know mechanically they work. One of the problems is, especially in elderly, especially on people who have other problems, is that the bone is molds around that device and it collapses. And especially if people have osteoporosis, literally the bone get the shape. When I have taken a lot of those devices out, the bone shapes like the negative to part of that device, and then it collapses. There's no question they work. In the spine, we don't use them anymore. Spine surgeons don't use them anymore, or most of the spine surgeons don't use them anymore, because we know that in the long run, within 6 months to a year latest, the bone molds around that, and you have the same problem back. There are two different kinds of these devices. One that keeps the integrity of the spinal process and fulcrum around that. The other one that you take it out, the interspinal ligament out, and you open it up and fulcrum around the disc. They have a little different profile, but David, what I tell about that is that 3 months, 6 months without pain is better than 3 months, 6 months with pain. So I have no objection, except that I have taken more of those devices out than I have put it in, literally.
sure.
I have taken like 30 of them out, because in the long run, we know they are not efficient. But you know what? In some of those patients, it takes them about a year or two for the pain to come back. So 1 or 2 years without pain is a big deal for this patient.
So Hamid, let me ask you, how hard is it to take these devices out? And does it
Easy.
preclude fusion?
It takes me 5 minutes to take them out.
So it's not a huge deal to just undo it and
It's
move
not.
ahead with something else.
Something that can happen is that if somebody has lots of osteoporosis, you put them in 2 weeks, it breaks. The spinal process breaks. It just, if somebody has severe osteoporosis, you better not do that, because the risks of putting that in is not really justified. If somebody has osteoporosis, you would know that it won't last 6 months. It lasts maybe weeks at best.
Sure. The other thing that pain docs are doing is, it's called the mild procedure, minimally invasive lumbar decompression. And we take a 5 millimeter tube, put it down to the ligament inflavum, and debulk the ligament posteriorly, right and left, or sometimes unilaterally. But that's for people who have this buckling forward ligament inflavum that's causing central stenosis.
Yeah.
And that's also, in my opinion, my feeling is you guys can do that much better than I can. 5 millimeter tube is really tiny, and it's hard to get anything out of there.
Now, it is, David, I know in our societies, lots of spine surgeons are going postal. other people doing things that we think we should be doing.
Exactly.
But let me tell you, if we were doing what we need to do, there was no reason for the patient to go somewhere else. You get people, we complain about that, but the reality of that is like sacroiliac joint fusion. We neglect those patients and we complain that when those patients come to somebody else to get help. And that is, I think, the tragedy of that instead of thinking about patient, we think about our territory and we become territorial. I teach everybody who can do that safely, I think they should do. And at the end of the day, for some of you know, I'm trained in Germany. In Germany, orthopedic surgeon, they think neurosurgeon has no place to put a pedicle screw in. So if I'm in Germany doing this scoliosis surgery, the orthopedic surgeon behave the same way that some spine surgeon here behave toward the interventionalist doing any procedure. They say, I have no business putting a screw in the bone. So we know all that I can do that. I'm trained enough to do that and have good result. I think as long as you are trained properly and so on, so I have no problem with that. But with the interspinal process and all those procedures, you just have to go through a process of learning how it's done safely. I don't do interspinal processes anymore because of what I described and because I have better options. Sunny, in this patient, do you think an interspinal process would be an option?
You'll have to put about 6 of them in, so.
Yeah, not a good option.
Yeah, no.
Yeah. So what else, David? I mean, what other option do you have for this patient? We understand that you cannot correct with the pain procedure the scoliosis, but in this patient wants to be pain-free and wants to walk. This is her goal, as Monica mentioned.
Right. So I think the pain doc's role in a case like this is if the patient is non-surgical, would implantable pain control technology help? And there are 2 implants that we do, neurostimulators and targeted spinal drug delivery with a pain pump. And we can try each of those without implanting the device. So a trial of a stimulator goes an entire week, but it's really good for neuropathic pain, like chronic radiculopathy that's there 24/7, not so much mechanical pain that's better when she rests. So I don't think stimulation would be helpful for her, but targeted spinal drug delivery will help just about anything. And the reason is we put bupivacaine, a spinal local anesthetic, into the intrathecal space, and we put the catheter tip where the maximal pain is. So in this lady, we might put, a lower thoracic catheter tip and infuse bupivacaine mixed with low-dose fentanyl, and that would give her some pain relief. Would it help her walk and stand better? I don't know. We'd have to see. But that could be tried too. So I think that's the realm of the pain doc.
Mm-hmm.
When we start trying to change structural things in someone like this, it's like you guys can do it much better than we can.
Yeah.
I don't think we
How
should do
often do you need a refill on that bupivacaine? Is that a twice a year type of refill, or
2 to 3 months, every 2 to 3 months. And it's pretty simple. So we have, like 850 patients with pain pumps in Minnesota because we've been doing it for 25 years, sometimes for cancer pain, other times for 10 spine surgeries and no more, surgical options. And they're quite effective.
bupivacaine sounds nice because it's non-opioid, right? So you don't go into that opioid dependence problem, correct?
Exactly. And if you think about it, the most effective pain relief is a epidural bupivacaine infusion. Like think of a labor epidural. We can stop labor pain. We can do surgery with an epidural, and we can block C fibers in the epidural space at low concentrations where people have retained sensory motor function of their lower body. The problem is it's a high volume system that requires an external pump and bag of fluid. So it's impractical for people who are not inpatients. So that's where intrathecal drug delivery is different. Now we're using, instead of 5 to 10 cc's an hour of an infusion, we're using a half a cc in 24 hours to get pretty powerful pain relief. So it's feasible.
Dr. Abbasi, would you consider at a very basic level, would you consider bracing for this patient?
Yes, I think obviously that is bracing is, I think, an integral part of treating the condition like that, because you remember when patient lays down, the pain get better.
Right.
Patient reduce the activity, pain get better. braces, the best, the braces these days they are made in a way that they don't completely, like, they are not the tortoise shell they used to be that eliminate all motion, but they eliminate the maximum range of motion that would provoke the pain and put a tremendous amount of pressure there. And as you know, it's one of our protocols. But let's go around. Let's see, Dr. Kim, what option would you have in your practice for this patient in civil?
Well, the patient is 60 years old lady.
Yeah.
And she has more than 20 years to be active in her life. And so we should more definite treatment for her to continue her life. And I should decide which level is the pain generator.
Mhm.
And there are multiple stenosis. And I would like to know which nerve root compression make her disturbed. The central compression is not so much problematic, but several levels of the radiculopathy with foraminal stenosis is the problem. And I would like to diagnostic nerve root injection and to make if her radiculopathy is relieved by the diagnostic, the epidural steroid blocks. No, the local anesthetic block. And I decompress the level and then prevent the instability after decompression. I should decide the fusion level. And I will do the minimal invasive spine fusion, but I may consider the TLIF for her problematic level.
If it helps, most of the radiculopathy is in the front and side of the thigh, some in the back of the thigh, no heel problem, no side outside of the, so practically mostly L2, 3, 4 radiculopathy, but very little L5 and S1 radiculopathy, or much less L5 and S1 radiculopathy, if that helps.
Right.
So now, certainly diagnostic nerve root injection can be valuable, very valuable to confirm which levels are diagnostic, but at least in the exam, it seems that most of the radiculopathy is coming from the upper lumbar spine.
Right.
So we talked about that, possibility of the stimulation device, pain pump, bracing, and as well now we are moving toward the fusion. We are talking about the TLIF and the decompression and fusion. Bob, you want to chip in, and what options do you have for this patient? You're muted.
Yeah, that may be a good treatment, but it is probably some limitations for the definite treatment for her. So I consider decompression and fusion will be the better option for her.
Yeah. So, Bob, do you want to say what option do you have for this patient?
Sure. I'm just like in Kansas City on the airport, so I'm sorry for the background noise. I just went to evidence and technology meeting of NAS last week, and there seems to be a little bit of well, not a little bit, a lot of decline of those large surgeries where I don't, somebody could say do T10 through S1 and put S2 screws and stuff like that. There is a general, people are thinking that the big surgeries have got so much complications that it is not worth it, like to deliver a full correction of the curvature and stuff like that. So you could decide either in my hands in between focal decompression. Just go in and decompress what you can with the least damage to the soft tissues. Maybe even do the one-sided laminectomy with undercutting to the other side, or you could do a fusion, because the fusion would be a better option here because of the significant collapse of the intervertebral disc spaces. So I actually would really defer to some sort of a minimal invasive procedure, either the OLIF that you do, or you could do combination of XLIF and percutaneous screws, and I would do it in a limited amount of levels. That is what I would do.
Yeah.
Yeah, thank you. And I'll mute it again because this is a horrible noise. Okay.
Dr. Fatih, if you want to as well, just tell us what you would do. You don't have to, but if you want to just tell us what would you offer this patient, we are eager to listen to you. What option would you give the patient? And then I will tell you what I did and what the outcome was. Go ahead, please. Okay, I think Dr. Fatih might be not connected, but either way. So based on the symptoms and based on the patient situation, I decided the most of patient clinical symptoms is coming from L1 to L5. I know, there's nothing wrong here. You could do multi-level laminotomy, just open up, that would help patient with some symptoms. But in my opinion, if you don't fuse, the axial pain is not likely to go away. And again, patient wants to walk and wants to be pain-free. So obviously in my hand, based on my expertise, I offered the patient OLIF. And I offered that patient based on patient's symptoms, even though patient is a fragile patient, for L1 to L5, not to S1. And I know now some people say, but then S1 is going to L5, S1 is going to fail. But based on our protocol, I prefer to do the smallest possible surgery that can give patient the maximum clinical benefit. But here, I couldn't really narrow it down to 1 or 2 level. I mean, I just couldn't. Look at that, the curvature and patient symptoms. I decided to address the L1 to 5. Now, scoliosis, even 60-degree scoliosis is not a problem for us anymore. But torsion is still a big deal. Look at that torsion, because there are new angles involved in a transcambine OLIF that you have to consider when you do OLIF. And especially if you look at that here, the spinal process turning to the right. Our approach is from the left is better. What's worse, if the spinal process turning to the left, but then that makes the approach from the left at a little awkward of a position. Now, obviously, we have to study the pictures. What OLIF enable us with 2 C-arm, we adjust for the segment that we are working, and then literally work on that segment and then move on. So this surgery was done not long ago. It actually was done about a month ago. And this is, as you see, this is adjusted only for L4, 5. You don't see L5, S1, but you see the pedicle. Are you guys able to see my screen? Everybody able to see my screen?
Yes.
Yes? Okay.
Yes.
Yeah,
Yes.
we can see it.
It is truly only adjusted for 4, 5. And now you see I enter the disc and and opens it up and put the tube in, do the discectomy, and then put the cage in. What you don't see, the cage is, I put it on purpose in the front because I want to create a good lordosis to reduce the axial pain. There are good studies there. If you can, you should reproduce lordosis. The way we reproduce lordosis is putting the cage in the front part of the disc. And then I go to the next level. Obviously, I put the K-wires in for those 2 levels. Now, I have to truly do a little change of the C-arm to adjust it for the next level. What you will see in the next C-arm, that if you look carefully, you see now in this picture that it almost looks that the cage is extruding. Are you able to see that here?
Mm.
And that is not because between the last 3 pictures and now the cage really moved. It is because I am angling the C-arm. Does that make sense so far? But let's go on. Let's go back and forth. Here, this is when it's adjusted to that level, and this is when it adjusted for the level above, with the torsion, considering torsion. Now it looked like that the tip of the cage is extruding out. And then obviously I go and you see that I'm opening it up, and then I take care of the other level. And again, I put it as far as I safely can in the front of the disc. And now I have to restart this. This system is not complying with me. So this surgery was done about a month ago, and I can show you the final pictures maybe instead of going all through that. Scoliosis was mostly corrected. Patient stayed, I believe, just 2 nights in the hospital. Surgery was about 1 hour and 35 minutes. Our blood loss was about 250 cc. So, and the patient did have what we call iliopsoas compartment syndrome. For people you don't know, especially if patient has torsion, you see that more. When you do more than 7 passes and you poke in the iliopsoas more than 7 times, and in a multi-level, sometimes that's what happens. You poke in the sheet of the iliopsoas, it swells up, and it causes people being weak in the iliopsoas. The hallmark of that for the OLIF, we know that OLIF has a risk of nerve irritation. That is, we know what the percentage of that is, but if somebody wakes up with a nerve irritation after OLIF, they wake up and the nerve irritation is there. Iliopsoas, the first day they wake up, they are fine. Next day, next 2 days, they become weaker in bringing the leg up. Some people come and tell me, patient is weak in the quad. It is actually, if you do a good exam, it's not the quad, it's iliopsoas. And you can distinguish that with a proper kind of test and exam. But more or less, we did the surgery went well, patient did have iliopsoas compartment syndrome, and 2 days later was discharged. Now, Dr. Aya is not here, but recently, last week when I was in Korea, Dr. Aya called. Oh, are you there? So why don't you tell us, Dr. Aya, when you saw this patient last week, what was the exam, what was the finding? And I'm going to bring now the post-op CT that we can together look at. So tell us about your exam last week.
Okay, so when I saw her in the clinic, she was a little over 1 week status post her surgery, around 10 days. So on physical exam, the most significant thing was, I would say about 3 out of 5 hip flexors, and then everything else was 4 minus. And then she had a subclinical foot drop. So, that was chronic.
Okay, so that is more or less the same exam I had before the surgery, except the hip flexor iliopsoas. Please go ahead. What pain level, radiculopathy?
Oh, so she told me that initially after the surgery, she had radicular pain that was just globally to her thighs, foot, leg, everything. But then after a couple falls, she said that the pain had resolved. So by the time I saw her, she didn't have any radicular pain anymore. It was just the motor weakness.
Okay. Now, in that case, we looked at some of the pictures together, and there was a question about and you said as well, patient had some low-level falls, correct? Low height fall, correct?
Yes, falls from standing height.
So patient is in the clinic, we have the and that is for us a routine. We get always post-operative CTs to have a baseline. Is there anybody else want to know any other information regarding this case? Is there any other information you would like to know? No? So let's look at the pictures. I'm going to go top to bottom. Tell me stop. Whenever you are interested in a specific films, you just tell me stop. So I'm going down. Obviously, what you notice, and if you measure it, the torsion is a little less. Let's talk top to bottom. In very small pedicle, sometimes I aim for lateral breach. There is a small medial breach, which we should look at more carefully here, what that medial breach is. This patient has, and this is L1. in the L1 lateral recess, we would expect if it's symptomatic, first of all, we stimulate them up to 25 in the surgery. So the stimulation did not return any signal for this patient in that level. We record all of that. So Dr. Aya, did patient have any new symptom that would correspond to that medial breach of the L1?
No, she only had left-sided symptoms. Her right side, she had neuritic or motor weakness.
Okay, so let's just put it around. Based on what I hear, no symptom related to that medial breach. I mean, who would propose we go and revise this? I mean, I wouldn't. Is a asymptomatic, a medial breach, I wouldn't do anything. Then with the torsion, sometimes it's hard to, really have a good view, but let's go to the next level. The cages are right, the screws, they're okay. They're right, they're centered on the pedicle. And in other views, they are good as well. And then the next level here, again, the screws are good, the cage is okay. And now we get to the 4-5. Again, the screws are here good, and this cage now. Okay, now let's talk about this cage. If you look at this picture alone, it almost looks like that cage is extruding out. Does anybody take a comment on this picture and ask question? Now, if we go back, as you know, CT is made in 2.5 millimeter intervals. And looking at this picture here, it seems that the body of the disc, body of the cage, it is within the confine of the bone. Yes, the tip is extruding out. And I think the most important thing is it moving? Is it a different situation before and after? My system locked on me here, so I cannot show you. But if you go and look at the pictures intraoperative, I don't believe this cage has moved.
Mm-hmm.
So, and the body is there. Now, what are the new symptoms? Certainly, iliopsoas compartment syndrome and hip flexors are new. The pain, obviously, I try not to make a decision just based on the axial pain, because after the surgery, patient will have pain. So, and based on that information I had last week, we talked about, I just didn't have access to look at all the films. We put the patient on a schedule to be revised, but as soon as I was back, I looked at the films and I actually examined, I interviewed the patient. Just this Tuesday, I visited with the patient. The pain is getting better, the radiculopathy is getting better, the strength in the leg is getting better, so patient overall is improving. So I decided not to revise this case. And so patient, and we are just about a month after the surgery. Actually, today is exactly 1 month after the surgery. And all those symptoms that I was presented in my interview, so there were symptoms that I was expecting to see of this patient. Now, most of the time, I concentrate on clinical symptoms, and I compared this to the intraoperative. I didn't feel that this cage is moving, and I decided not to revise that. Now, obviously, I will watch this patient very closely, maybe every 6 weeks or 2 months. We will get more pictures and so on, and we will reduce the activity. So the things that are here could be a problem for the future is, number one, is that cage stable? Looking at that, already bone is growing. Look at that density of the bone inside of the window of the cage. And as well, if you look, the cage is actually indenting into the bone to some degree. I think unless patient falls, that cage is stable. The number two concern here is the L5S1. And I have learned the hard way, solve the future problem in the future. Meaning, yes, patient may have problem in the L5S1 in the future, but patient's typical radiculopathy that patient had before the surgery in my visit last Tuesday was gone. So sometimes patience is a virtue, and these surgeons want to fix things, but sometimes it's hard not to be proactive and say, you know, this is good for now, and not to fix it. So I decided not to take this patient back to surgery and fix it. Now, I'm going to open the floor, and please criticize this. Most of the cases that we do are never perfect. And this was a difficult case because of the torsion, and another problem that was intraoperatively, because patient has osteoporosis, the bone density is reduced. So pictures in the surgery, they weren't perfect. And I want to show you, if the system work with me, I want to show you some other intraoperative pictures to show you exactly. I mean, sometimes it's hard to see all the pictures, but I'm going to show you first my final intraoperative lateral, which is here. And as well here, almost it seems that this level is a little extruding, but if you adjust it for that level, it's less impressive. So, and these are the AP picture of the same patient, and you see most of the scoliosis actually you can correct. And here you see why this cage is all the way to the other side. So I had to choose a place. We have shown in our study that we can correct up to 5 to 7 degrees scoliosis per level by very meticulously choosing where that cage ends up. This is obviously not as a big profile cage like XLIF cage, so definitely that's not as optimum like XLIF cage, but I want to emphasize again, this surgery was done in 1.5 hours with about 200 cc or 180 cc of blood loss in one position. So, and here is, you see how it's lifting up that segment as you see. And so practically this patient, right, and look at that, how scoliosis get corrected. Pay attention to this. And that is what the position of the, are you able to see that the entire spine changes when we position that cage? So, and that is the upper level. And here, obviously, I put the cage more toward the left and midline. Well, no, not really, didn't accept that because of the torsion, but, and I'm going to show you just the finals as well here. And again, this machine is not working with me. So what question do you have, or what suggestion? What could we do better? What else could we have done to optimize this patient?
Can I add?
Yes, please.
I tend not to use the cages to the correction. I try to put the cage in the most optimal position, because you want to cover the entire cross-sectional area to create the fusion.
Okay.
And I actually correct the scoliosis by intraoperative patient positioning.
Yeah, that is
this type of multiple level fusions. You have to extremely hyperextend the hips because you don't want to create a flat back deformity. So I don't use a Wilson frame. I use the full poster frame. I put 3 pillows behind each knee, so hips are hyperextended. That automatically, the force of correction there is so powerful that that's going to really preserve your lordosis.
Mm-hmm.
And when you also, in order to correct the coronal plane deformity, after you put the pedicle screw in, you can actually push on the patient before you tighten the nut. So you do just like a chiropractor adjust the spine, you can have assistant push on the convex side. Okay, that's a very powerful force. It's like a wrestling with the patient.
Yeah.
It's already under general anesthesia. So you can put a force and counter pressure. Mm-hmm. And when you tighten the nuts on your perk screws, you can fix that in that position. Yeah. That's much more powerful than I don't rely. I try to put the cages in most optimal position and not use the cages.
Yeah,
Try to correct the scoliosis.
yeah,
That's
and
my comment.
absolutely. In the last year or year and a half as well, I have come away from Wilson. I'm using as well for Poston, which I do believe you are right, very powerful, and with putting some pillow underneath, not to put the patient in the kyphosis, but in the lordosis. Yeah, that.
One additional comment. One additional comment is that I would have done L1 to L5, and I try to avoid L5S1, just like avoid it at all costs. Because if you do a L1 to S1 fusion, you have to use a S2 iliac screw.
Yeah.
Comes you add additional at least an hour to the procedure, especially in a lady like this.
But,
so my hats to you that you decided not to go down to the sacrum.
And I'm very well aware of that. But Sonny, in the end of this year, doing the iliac screw is going to add 3 minutes to our surgery. John,
Right.
do you talk about our iliac crest bolt that we are developing? You want to talk about that?
Yeah, so essentially, and Ken can obviously give more details, but we're in the process of launching within the next 6 months a percutaneous screw set, which includes a couple of unique and quite frankly revolutionary features, one of which is what we've termed an iliac bolt. So what this effectively does is, instead of if an iliac screw is required, instead of having to place that screw to provide that pedicle so you get the extension for the rod in an open fashion, we're able to install this essentially a pedicle that's held on by a bolt in a minimally invasive manner.
So, 90% of my screws that have failed have been S1 screws. And I'm pretty sure most of spine surgeons have similar experience. And that is not only because it's the lowest level, but as well, you put the shortest screw in S1, the angle of attack as well is there's more weight on it, but as well, most of the motion is concentrated there. So for that reason, most of spine surgeons, we are just concerned about the failing of this one screw in long construct. Son is absolutely right. We prefer to have 2 points of fixation, that maybe S1, S2, maybe S1 and iliac crest. But the problem is putting truly MIS S2 or iliac crest screws is a big deal. The 5 people I know in the planet did that. They quit doing that because it just wasn't working. It wasn't properly working for them. Now, the system we have, and I invite you to come to our labs and watch that, within 3 minutes, it takes you less time to put the iliac crest bolt, not screw, than it takes you to put a pedicle screw. And by the way, the bolt, by the compression, we measured the mechanic of it on a finite element model, is 2.5 times stronger than a screw. The iliac bolt, it goes on both sides of the iliac crest, compresses it, and aligns the head of the bolt, and you behave like that, like a regular pedicle screw. So I invite you to come into one of our lab and see that bolt, how it's working. And that hopefully by the end of the year, Sonny, we can do something nobody else can do by truly minimally invasively instrumenting all the way from T10 to iliac crest, all MIS. And really my thanks to my engineer team that they have done a marvelous thing. That is truly a marvelous thing that we are able to do that within 3 minutes. We did it with the prototypes in a cadaver lab. It took us 3 minutes to put the iliac bolt in, and it's solid. It's more solid than any, especially in osteoporotic patient, that when you spread the load and you compress the iliac crest, it's truly mechanically stable.
I also like to add what you did in 1.5 hours in very experienced spine surgeon's hand with at least 20 years of experience open. That would have taken 6 hours at least.
Yeah.
The T-lift 5 levels, all those pedicle screws and cages and all of that, that's at least a 6-hour case.
But what I want to emphasize is,
An hour and a half. So
Yeah.
that makes it truly minimally invasive.
yeah, and that is that. But I think that the truth fact here is that it's not only I can do that. You do 2-level fusion in 1 hour. Other people can do that. It's truly, certainly their surgeon skills are a factor, experience is a factor, but truly this is a technology that allows us to do this kind of efficient surgery. I don't call them fast, I call them efficient. And we have a track record that everybody who goes through the learning process is as efficient as you are and as I am after a certain number of the cases. What I'm truly proud of is that people who join us, they get faster than I in shorter period of time. That is truly the nature of it, that they don't have to do my mistakes. I give them what can go wrong and they don't have to repeat that. So like Sunny, we have been keeping track of your times and your efficiency. It took you 1/7 of number of the cases that I needed to do to get as efficient as I was. Like within 50 cases, you had the numbers that I had after 250, 300 cases.
No, I would like to use the analogy here. I mean, it's just like thinking outside the box. Cardiac surgeons out of business, they're out of work. Why? Cardiologists, remember they used to open heart surgery and put a CABG procedure?
Yeah.
Cardiologists doing stents. So right now we're doing stent procedure where all the other guys are doing open heart surgeries. It's just like thinking outside box. It's a paradigm shift. We are doing stent procedure. It's a radiological procedure where other guys are doing open TLIP procedures, open surgeries. I've done open surgery 25 years.
Yeah.
It's an analogous cardiologist versus cardiac surgeons. You want to be a cardiologist for the patient.
And even though you don't have the glory of being a cardiac, opening the heart and so on, but if patient is all what matters,
that's correct.
And get discharged within 24 hours or 2 days. They don't stay in the hospital for 2 weeks or a month.
The stents, they go home the same day. When the cardiologist put the 3 stents in, patient go home the same day. Open 3 vessel CABG, it's a 1 hour, 1 week in the hospital with the pulmonary bypass machines and all that stuff.
Yeah. And so we have 10 years of data that shows what the result for our patient is. And I think that is why we are expanding. That's why we are announcement. Our surgery center is opening in about 2 months, I'm told. Maria, do we have an update?
Sorry, yes, everything's on track. We're, commencing with the Department of Health to come out and do the survey as soon as, the construction team is done. So we are fully anticipating doing surgery in our own surgery center in April.
And as well, we signed, not closed, but signed on buying a 39-room hospital in Texas. So what we are doing, Sunny, you and I are on the right path. What we are doing, patients recognize that and they are flooding us. They are coming to us. That is why we can afford to buy that hospital in Texas, because we know where we are and what we are doing. So kudos to all of us that, we have put a team together that can help us to pull the next step. And I like your analogy. We are the stents for the patient, because that's what's good for the patient.
Correct. That's correct.
Well, now I open the floor for final remarks or comments. And again, this was one of our complex cases, and obviously patient had Iliopsoas compartment syndrome. So this is a patient that we had complication. This wasn't our regular 3-level fusion that I just did 3 days ago, and in the 1.5 hour or 1 hour and 15 minutes, and patient was discharged literally next day with a BMI of 50. So we have lots of glorious cases. This was our not glorious cases that I presented today with complication, which is Iliopsoas compartment syndrome. Now I open the floor for final remarks, but then we can close this month's meeting. Any question? Okay.
Congratulations for excellent.
Thank you. Thank you very much. Well, thank you very much, everybody. I think we have a meeting with Dr. Milani, right? So
yes,
then we can just stay on, and I want to introduce you to Mike Hansen and